Okay, so thanks everyone. Thanks, Mark. I have a bunch of information, so I'm going to try and get through everything real quick, just so everyone gets a good rounded perspective on what we do at Vector Medical, but most importantly, what some of the issues are and some of the trends we're seeing in medical cannabis. What I'm going to talk about is not only relevant to medical cannabis. The use of cannabis, whether it's legal or whether it's recreational or whether currently what's considered sort of technically illegal. The use of cannabis and the products that people use, whether it's medicinal or recreational, are essentially the same. So the types of impairment I'm going to be talking about are lessons and trends that we've gleaned from companies we've worked with and employees that we've evaluated. But it's also going to be extremely relevant to all of the issues you're going to see when cannabis is legal. So a little bit of background before I just jump into everything. I'm going to be talking about some case examples, not specific case examples, but trends that we've seen in dealing with employers that have referred employees to us for independent medical evaluations. So our company sort of picks up where Paul was saying the SAP assessment leaves. So, we'll be involved in evaluating and scrutinizing the prescribing physician's perspective when that prescribing physician says that individual is safe to return to safety-sensitive work. And the employer takes a step back and says, well, wait a second here. We want to make sure that that's a true statement, that it's actually that returning that person to work is going to be safe, and we want an independent expert opinion on that. So with that background, I just want to step into and jump into everything. So currently in Canada, this is going to change in the summer of 2018, but currently people get cannabis through licensed producers. If they have medical authorization, they can grow it at home, and some people grow it at home illegally, but there are also people that can have a medical authorization document that authorizes them to actually grow it at home. And this was through a Supreme Court injunction having to do with primarily someone who was baking goods who was arrested, who eventually was able to, under the Charter of Rights and Freedoms, to continue to extract oils and extract the psychoactive ingredient from cannabis and make baked goods. There are illegal growers and dealers, and this is how people have gotten cannabis in Canada for many, many years. And then there are dispensaries, which have the front of being a medical cannabis type of institution, but in reality, they're not really any different from the illegal dealers or growers. They're just a storefront that sells illegal marijuana. So that's currently how people get marijuana in Canada. The LCBO and other types of retail distribution are going to be leading the charge in 2018, but that's currently where it's at. There are different types of medical cannabis products that people use. There are synthetic cannabinoids that have been available since the late 90s, and these are synthetic. They're produced in labs, and they are pharmaceuticals. So you can get it through an actual prescription through the doctor, and they have a designated DIN number. I forget what it stands for, but you can get it through Shoppers Drug Mart or Rexall or any pharmacy. It's different than the medical cannabis that we see. There's also fresh plants that people can buy directly from licensed producers. You can actually buy seeds. You could buy a full plant that you can then plant at home from a licensed producer. There's cannabis oils, which you can buy from licensed producers, and these can be smoked or cooked or baked. You can also use a dropper and drop it on your tongue. This is another type of medical cannabis product. And then there's dried herbal cannabis, which is far and wide the most used type of medical cannabis product. It can be smoked or vaporized, also cooked or baked, and it can also be eaten raw. So people use these different products in different ways. I ended with dried herbal cannabis because it's becoming more and more potent. And the issues that we are seeing in the workplace having to do with impairment, having to do with worker safety, are directly related to the potency of cannabis that people are using, both for medicinal purposes and recreational purposes. when we look at the onset and the duration of effect, when people ingest it orally, so this is either through an oil or an edible, it has a slow onset. So it takes about 30 to 90 minutes to kick in, but then the duration of effects lasts pretty long, so 6 to 8 hours. Whereas if people smoke it or vaporize it, it has a rapid onset. It takes minutes to kick in, and the duration of the acute effects, when the person is high, lasts only 1 to 4 hours. So coupled with the potency of the cannabis products that are currently available, these different routes of administration and duration of effect are important because they impact the way that it affects the brain. There's, as you can see, the distribution of CB1 receptors in the brain are located in key areas of the brain that have to do with impairment that it could impact safety. Is there a pointer on here? Oh yeah, perfect. Okay, so we have decision-making, cognition and emotional behavior, memory and learning, the cerebellum, motor control and coordination, regulate voluntary movements. There are key areas here that we've talked about and that everyone sort of touched on, that if that person is using cannabis and they are using high-potency cannabis through different ways of ingesting it, it's going to impact areas of the brain that cause impairment that could create significant safety and performance issues in the workplace. So now I'm going to get into what these safety and performance issues are. And again, these are examples that I'm going to relate to different types of impairment. And the question is there any way to know if an employee is impaired? So I'm going to talk about 3 types of impairment: acute, residual, and withdrawal. And for each type of impairment, I'm going to outline a different trend that we've seen in the different independent medical evaluations that we've done. So with acute impairment, the trend that we see are workers whose physicians claim they need to use dried herbal cannabis with high THC content, so 10 to 25%, throughout their workday to control the symptoms of their health conditions. So these are people who are using cannabis all day long. So usually 2 to 3 grams a day. And their doctor is saying they are allowed to come back to work. Here's what the workers and their doctors typically say: I'm not impaired because I've developed tolerance. So I use so much marijuana and I've been using it for so long that it no longer impairs me. And these are individuals who have been cleared to return to safety-sensitive work and use marijuana in the workplace. And again, this is totally outside the context of what your alcohol or drug policy says. That's not what the prescribing physician is considering. It's not anything they really know about unless you tell them. And this is typically what we're seeing for people who were concerned about this acute impairment piece. The science is pretty conclusive about this issue. Acute impairment is when that person experiences being high or euphoric, and it lasts for 1 to 4 hours after inhaling marijuana, either through smoking or vaporizing, or 6 to 8 hours after oral ingestion through eating it. There are different variables that affect the duration of impairment, such as the amount of cannabis used, the potency, the method of consumption, the age, sex of the individual, or the complexity of the task. And there's individual differences there, but neurocognitive and psychomotor performance is impacted regardless of cannabis use history. So that claim that I'm tolerant and therefore I don't experience impairment is kind of not, it's false. Tolerance does not prevent acute impairment. No matter how much marijuana a person uses, no matter how tolerant they've become to it, that person is still going to experience impairment in that 1 to 4 hours after they inhale it and that 6 to 8 hours after they've orally ingested it. Acute impairment impacts psychomotor and cognitive performance, and we've talked about a lot of these different issues, so I'm just going to quickly go through it. And the conclusion to all of this is that workers using cannabis with moderate to high levels of THC while they're at work will likely experience impairment that affects their safety and performance. So that's kind of the obvious one. We all know people should not be using cannabis products while at work in a safety-sensitive work environment, and most likely in a non-safety-sensitive work environment as well. But when we get into residual impairment, this is often a factor that people don't consider. people don't really think about the residual impairment thing, which is sort of like a hangover after drinking alcohol. A person will fail a breathalyzer or an alcohol test if they're still hungover or significantly hungover. But the type of testing that we have for THC and for cannabis is different. It screens for how recently that person's used, and we don't really hear about this type of issue. We hear about, is that person high at work? But there's other types of impairment that the person can experience. So the trend that we see here that's most relevant to residual impairment are workers who use less than 1 gram of marijuana per day with low to moderate levels of THC for intermittent symptoms. So people who are using it for insomnia, for chronic pain or low back pain, or for anxiety symptoms. And these are people who are not using it necessarily on a daily basis. These are people who are using it when their symptoms present themselves. And what the workers and their doctors typically say is, I'm only using a small amount of cannabis with relatively low levels of THC, and I'm never using it at work, and the implication is, therefore, I'm never high at work. The issue is that non-acute impairment occurs during the period after the psychotropic effects of cannabis have subsided, so after the individual has stopped being high. And this residual impairment can last for 24 hours or longer after the person has stopped using cannabis. Studies have shown that residual impairment can last for up to 28 days, and even low doses of THC can result in performance deficits days after use. So there is a large body of research that talks about this residual impairment, that even though the person may not be high anymore, 1 to 4 hours after inhaling it, or 6 to 8 hours after orally ingesting it, that person could very well be impaired 24 hours to 28 days after they've used cannabis. So even if an individual is using it once every 2 days for insomnia when they can't sleep, there's a likelihood that they're going to experience some type of impairment at work. And the type of impairment that they experience is a little bit different than the acute impairment piece, but it's also very similar because it's affecting those same areas of the brain. So of course there isn't any drug test to evaluate this impairment. No one ever talks about drug testing people for residual impairment. It's always about, we're trying to test that individual either through urine testing to see if there's the substance in their system, or through oral fluid or blood testing to see how recently that person's used. But we're never talking about drug testing in terms of looking at residual impairment. It's the deficits that people experience through residual impairment include episodic memory issues, attention, concentration, abstract reasoning, and decision making. And a very important point is that individuals experience residual impairment in neurocognitive and to some degree in psychomotor functions, despite their subjective perception that they've returned to baseline mental status. So people don't realize that they are experiencing this residual impairment, like the study that Melissa was talking about with those airline pilots who were, a significant number of them were experiencing impairment 24 hours later on their simulator test. The conclusion to this piece is that workers who use cannabis with low to moderate THC levels outside of working hours are still likely to experience residual impairment that can affect their safety and performance at work. So again, we're not necessarily worried that they're high at work. We should also be concerned about the issue of residual impairment 24 hours to days after they've used. Withdrawal is the last type of impairment that I want to talk about. I also have a fourth trend that we've seen that's going to sort of round out everything. But the withdrawal symptoms are pretty unique, and they're also an area of impairment that people don't often talk about, that people don't often consider. The trend that we see here are workers who use 1 to 2 grams of dried herbal cannabis with moderate to high levels of THC every evening after work and do not use for 12 hours before work. And this could be for insomnia, it could be for eating issues, it could be for anxiety. People who experience these issues in the evening and they're taking marijuana to deal with these issues outside of working hours. And the claim that we typically hear is that there's enough time between my last use and the time that I work that there's no way that I'm still impaired once I come back to work. So take the issues of acute impairment and residual impairment off the table, and let's talk about withdrawal symptoms. Symptoms of withdrawal are said to occur 24 hours after last use and can be present within 12 hours. Common symptoms of withdrawal associated with cannabis abstinence are anxiety, irritability, anger and aggression, insomnia, decreased mood and appetite, as well as some significant issues if people are going through with severe withdrawal of tremors and shakiness and dizziness. All of these withdrawal symptoms can potentiate impairment and create problems in the workplace. So here's the conclusion here. Workers who are regular or daily users of cannabis are likely to experience withdrawal symptoms that can affect their safety and performance at work. So the claim that we hear time and time again is, I don't use 12 hours before work. I have a 12-hour window, which is longer than that 6 to 8 hour window of being acutely impaired. And therefore, when I get back to work, I'm not high. So like I said, let's take that whole residual impairment piece that I just talked about off the table. People who are regular users are likely to experience withdrawal symptoms within a 12-hour period after they finished using. So at the start of their work shift, they're starting to present with withdrawal symptoms. Again, that can impact their performance and safety. So this is just another consideration in terms of impairment that a person can be experienced that would impact their safety. And the last trend that I wanted to speak about is something that we're starting to see over and over and over again, and these are individuals who are using cannabis for medicinal purposes. No one really abuses cannabis oil without THC products in it for recreational purposes. It's just something that we're seeing within the context of medical cannabis. Now, the reason I've put CBD only in quotation marks is that there is not really any cannabis oil that has no THC in it. In order for it to be a cannabis oil, by definition, it's going to have a certain level of THC in it. 0.8 to 1% is usually what we see. But the claim that we typically hear is, I do not get high from my CBD-only oil. Okay, so the scientific evidence is inconclusive. Anecdotally, what we hear time and time again from the prescribing physicians is that CBD is said to not cause any euphoria or acute impairment. People don't get high from it. And it's generally consistent again, across all of the medical cannabis physicians that we've talked to. However, there is no conclusive research to say that CBD does not cause any impairment. So it's nuanced, but follow me here. Anecdotally, CBD is known to have side effects like drowsiness and attention issues, like any other type of medication that has potentially impairing side effects, like an antidepressant medication or an anti-nausea medication. Some of those medications that you would likely have in your alcohol and drug policies as medications people have to disclose if they're taking, and they work in a safety-sensitive position. So whereas if we're going to take it at face value that people don't get high from these oils that have very, very low THC levels in them, it's not necessarily to say that the person isn't experiencing any type of impairment. And additional research is required on this, and it's a very gray area and I think it's probably going to be decided in arbitration, and we may very well be the ones who influence decisions in that area, but it's yet to be seen. The conclusion is, while CBD is said to not cause euphoria or being high, it is known to cause impairing side effects and may affect a worker's safety and performance at work. In the absence of conclusive research, employers should err on the side of caution with regards to this. So we don't have conclusive evidence to say that CBD is whether it's impairing or not. But all we're kind of going on is the anecdotal experience of prescribing medical cannabis physicians who say, most people that I prescribe to say that they don't get high from it. But on the other hand, a lot of people who are prescribed CBD, especially initially as they're taking it, do experience symptoms of drowsiness and dizziness. Primarily, those are the issues. So there is impairment from it, But I want you to think about impairment more broadly than just people being high at work or people being drunk at work. And again, there are yet to be a lot of precedents set with regards to considering residual impairment and its impact on safety. But it is something that needs to be considered, and it is something that needs to be evaluated very carefully before putting someone back to safety-sensitive work, before giving that person medical clearance to go back to safety-sensitive work. So I'm going to just go quickly through the investigation process, and this is the process that we typically go through in an independent medical evaluation. It's also a process that your occupational health staff or your HR staff can go through in order to, as an initial screen, to see whether or not you feel comfortable putting that person back into their job. Inquiries into the employee's utilization regimen can help to tell you whether there are concerns regarding impairment. So this is the initial investigation when you're speaking to the prescribing or authorizing physician. What kind of cannabis product has been prescribed? I talked about those 4 different categories. Is it a synthetic? Is it a dried herbal cannabis product? Is it an oil? The different types of products will tell you how that person's typically ingesting it. What is the dose of the prescribed cannabis product? What is the THC or CBD concentration? How is the employee ingesting it? When does the employee use his or her cannabis? And is the employee medically fit to perform their duties of their job? What you want to ask the prescribing physician, what you want to ultimately determine is, are they fit to perform those specific duties? Now, if you start to ask the prescribing physician to clear an individual for specific duties, as opposed to saying, well, you know, this individual operates an oil rig or works on an oil rig, do you think they're fit to do their job? You can provide a PDA or a JDA, job demands analysis, and go into the specifics of that person's role to determine whether or not a physician will clear that person for safety-sensitive work. And when they have to sort of go through all of the different tasks involved in that role, then it starts getting them thinking, and they're often less likely to clear that individual. Inquiries into previous trials of treatment or medications can tell you about the availability of alternative treatment options. So the first issue is whether or not that person is impaired. That's really what you're concerned about as an employer. But there are also a lot of people that are authorized to use medical cannabis that really shouldn't be using it in the first place, or who aren't receiving any therapeutic benefit from using it. And if they're insisting that they need to use it, and that they're insisting that they need to come back into a safety-sensitive position, and you have concerns about that, you can inquire about whether or not medical cannabis is the best treatment option for them. And if it isn't, and that individual still, digs their heels in and says, I need to be using that, well, it gives you a little bit of leverage to say, well, maybe you should consider alternative treatments. So what is the condition that the person is using cannabis for? Now, if you have an HR department that cannot be privy to this type of sensitive medical information, then it's most likely that you're going to rely on an independent company to gather that medical information and make decisions on it, and then they could provide you back a sanitized report or information that doesn't go into the specifics of that person's medical condition. But what types of treatments have been trialed to date? What was the response to the treatments? How long were these treatments trialed? Why were these treatments not successful or not tolerated? And are there objective or quantitative measures of functional improvement with cannabis? And lastly, are there contraindications? Okay, so these, I think you're going to be receiving these slides. So these are the types of questions that you want to consider. But I want to end with some of the red flags that you should consider that would be answers to some of these questions that I've posed that should potentially make you concerned or should potentially require you to investigate a little bit further. If the person has no authorization document, so they think they're using cannabis medicinally, or they're trying to get you to think that they're using cannabis medicinally, but they've gotten it from a dispensary. We've heard stories about people who have gotten Skype consultations with doctors in Russia or India, people who are not actually licensed to practice medicine in Canada. or people who just walk into dispensaries and they're given cannabis with the instruction to go to their doctor and get a medical authorization document, but they're given the cannabis right there in the dispensary. So they're getting their prescription before they've actually received the prescription. So if someone doesn't have a medical authorization document, they are not a medical cannabis user. They have authorization to use more than 3 grams per day. That's considered a lot of marijuana. It's a red flag. If their method of consumption is smoking cannabis, that's a contraindication. A lot of physician guidelines say that people should, if they need to inhale, they should be using a vaporizer, which is a different, heats up the cannabis to a level where it's not burning it, but it just releases the THC and is less harmful to a person's lungs, doesn't cause that tar for people that people are inhaling when they're smoking it. If they're using high THC chemotypes, so the College of Family Practitioners of Canada recommends that people do not use cannabis products with more than 9% THC in it. 90% of the medical cannabis products available through licensed producers contain way more THC content than that. So there's a little bit of a disconnect between what the doctors are saying and what's happening in actual practice. People who are using during or in close proximity to working hours and have been authorized to do so, that's a red flag. Insufficient trials of first and second line treatments. So people who are using cannabis for their headaches, but they've never tried Tylenol or Advil, or they don't want to because they don't like buying drugs from pharmacies. There's no follow-up appointments with the person's authorizing physician. So the person has gotten a medical cannabis authorization document for a full year, and they're not instructed to follow up with that prescribing physician for the entire year, and they never see them again, actually. There's no objective or quantitative measures of functional improvement. What you'd like to see in a medical cannabis relationship between the doctor and the patient is that at baseline, when they come in, to have a discussion around how is your life impacted by your health condition? How is your pain impacting your activities of daily living? Are you not able to dress yourself? Do you have difficulty climbing stairs? Do you have difficulty cooking? And looking at what level of functional impairment that person has. And then at every follow-up appointment to administer those same types of questionnaires so that you actually see objective, quantitative improvement. So whereas a person may have not been able to climb stairs at all, if they're able to sort of climb half the stairs at their second follow-up appointment, well then you see that there's actual improvement from the use of cannabis. But what we typically see is that people say, well, cannabis is helping me with my anxiety, but what you see when you have a more in-depth conversation with the individual is that all of the issues that they were having that they were not able to do because of their anxiety when they first started cannabis have not actually improved. So there's this subjective experience of, well, cannabis is helping me, I like it, but then objectively from a medical perspective, it isn't actually helping them. If a person has a history of psychosis, it can be worsened or triggered by cannabis. The person has a history of a substance abuse issue, whether it's a cannabis use disorder or any other type of addiction issue, that's a red flag. If a person refuses to consider alternative treatments, and most importantly, if that person has clearance to perform safety-sensitive or decision-critical duties. Now, decision-critical duties are a little bit controversial in terms of how we investigate that, what is defined as decision-critical, and is decision-critical, does it fall into the realm of safety-sensitive? But I'll leave that just as a definition. Decision-critical is typically decisions that may impact on a person's safety, and we often hear about people defining decision-critical as decisions that may impact the financial status of the organization significantly as well. So that's what I wanted to leave you with. These red flags are important to consider, and I think it's Q&A time now. Thank you.
but so as opposed to the residual versus the acute, the withdrawal symptoms are similar, or is it just the anxiety of the person withdrawing that causes them to be, it's problematic in the workplace?
So the symptoms of acute impairment, residual impairment, and withdrawal, there are similarities, definitely. The withdrawal symptoms are less to do with the psychomotor issues and more to do with attention. So if the person's anxious, their attention is going to be divided, and it's going to be difficult for them to focus at work because they're going to be anxious, and that anxiety loop that people have when they're anxious, concerned about one thing or another, whether they're anxious about a specific issue or several issues, they're going to have a difficult time focusing on their work task. With acute impairment, it's neurocognitive and psychomotor. So it's attention span as well as reaction time. So that's the most concerning piece. And then the residual impairment, which is sort of the middle piece that I talked about, is also less about psychomotor, but more about attention. So the attention and retention of information and recall of information and concentration. So does that answer? Okay, great. Am I fielding all these questions? Oh, okay, great. Jeremy? I thought, yeah, okay. I'll stand here then.
So we talked about THC and we talked about CBD and potential risks with THC also being more psychoactive. Does anyone ever get into detail with sativas versus indicas? Because sativas are supposed to give you energy, whereas an indica is supposed to make you more like a couch potato.
Mm-hmm.
Does that ever get into it? Like if someone's obviously both comparing, but
yeah, well, I mean, there's also the flavonoids and the, what's that, Melissa? What do they call it? Like the different flavors? Terpenes, right? There are all these different aspects to the medicinal properties that have been theorized. What we really know the most about is THC and CBD and the cannabinoids within the plant. So whereas, you can have an indica strain and a sativa strain that have the exact same THC and CBD content that people report have different effects on them. But I haven't seen anyone making comment on those issues in the same way that I haven't seen anyone making comments on whether the flavor of the cannabis has a different impact on their impairment, or the flavonoids or the terpenes, which is the smell. Yeah, so it's a great question, and I mean, it's very nuanced, and I don't know if it will go that route. I've definitely heard physicians talk about the medicinal properties of flavonoids and terpenes, but not necessarily in the context of how that impairs a person or what kind of cognitive or psychomotor issues that causes. Right. Yes?
So this is the first time that I heard that there is synthetic cannabis, and those have a drug identification number?
Yes.
Correct? But in the workplace, should we be dealing with synthetic cannabinoids in the same way that we're dealing with cannabis obtained through dispensary?
Right, that's a great question. So we typically deal with synthetic cannabinoids, and it's a little nuanced because there are synthetic cannabinoids that are street drugs that are also produced.
The situation is, I think, I had an employee disclose that they had been prescribed cannabinoids, and I had their name, but I can't remember.
Is it Nabalone or?
Yeah, and I'm just thinking now it may have been a synthetic cannabinoid. We went through the process, had everything checked out with our occupational health provider and the medical doctor, but I wasn't aware that those had a drug identification.
Yeah, there are two of them. There's Nabalone, which is a completely laboratory synthesized molecule. It's a sort of parallel to the THC molecule, but it's produced in a lab. And then there's Sativex, which is an extract, so it's THC and CBD in that spray. So Sativex is a little bit more problematic in the sense that it's not the half-life, like it's a very expensive spray, and there's supposed to be specific dosing because you know exactly how much there is in the bottle, and you know exactly how much there is when you spray it. But in terms of metabolizing it, it's a little bit more complicated than when you have the Nabilone. And Melissa, am I explaining this correctly?
So, and the other differentiation, those were the two ones I spoke about at the beginning of the prescription. So, the Sesamet will not show up on a drug test because it is synthetically related to THC or similarly is not THC, whereas Sativex will. But the amounts, even with Sativex, compared to what people are getting at a licensed producer, is vastly different. So it's not 30% THC. It is THC and CBD. And so it can be impairing, but I would investigate that the same way you would with any other prescription medication, like an opiate or amphetamines, et cetera, that may be impairing. Because they absolutely can be. But, Aaron's right, like, you get a prescription, you're filling it at a pharmacy, you can get it at one pharmacy, and it's supposed to last you X amount of time. So in theory, they could take it all in the first 2 days and be very high, but then they wouldn't have anything left for the rest of the month.
Right.
So
And
different ways of investigating.
And we deal with Sesamet. It's also called Nabilone, different like the generic name. And we deal with that the same way we would deal with any type of impairing medication that's prescribed. And that's typically the discussion. You're welcome. Yes.
Just kind of a two-part question. How difficult is it to get this level of detail of information out of the patients? And I guess in terms of some of these red flags that I see here, for practical purposes, an employer, so what? Right? So if there's no follow-up appointments with an authorizing physician, are we not going to end up with a no safety-sensitive, restriction as an accommodation anyway? Like, how do a lot of these red flags affect where we end up with these?
It's a great question. So if the individual has no medical reason to be using medical cannabis, objectively, so you have a doctor who's prescribing it, but that doctor has essentially made an error, then you may have some leverage to say, well, we're not going to accommodate you. You shouldn't be using this medication. We have an independent medical opinion that says you should be using something else for your health condition. And if that individual doesn't consider that, then how actively engaged in this whole accommodation process are they? So that's why it's important to investigate whether or not cannabis is actually objectively helping their health condition. And one of this red flag that they've never followed up with their authorizing physician indicates that, yeah, I mean, they were prescribed 5 grams of marijuana a day for the next year. I think that's the full length of time that they can get their authorization document. And no one's ever followed up with them. And we just have no idea what's going on with whether their health condition is being helped or not. And when we get those individuals, what we often see is that they have a cannabis use disorder. I mean, like no one's following up with them. They're using as much marijuana as they want to use a day, and they're not getting any better, and now they're in trouble with their workplace. So there's just all of that happening. Now, it all kind of depends on the risk tolerance that you guys have as employers, whether or not you want to dig your heels in and fight that fight. Sometimes the employers that refer employees to us for assessments only want to look at the impairment piece. But we have, I'd say in 90% of the evaluations we do, we're also looking at whether or not cannabis is the most effective or an appropriate treatment for that individual's health condition. And we'll make alternative treatment recommendations. So people who are using it for psychiatric disorders, we've seen 3 cases where people were using it for bipolar disorder, who, when we evaluated them, were actively psychotic. And they were continuing to use cannabis, and their doctors were continuing to say that it's okay, but these people were paranoid. Like, we had one guy show up to the assessment 3 different times, and every time when he was supposed to sign the consent form to go through with the assessment, he came up with some other theory about how like he was just paranoid, and like he couldn't get over it, and it was like we didn't even have to get him to go through the assessment. It was obvious that that person was actively psychotic and really, really, really should not be using cannabis. So that happens too. And I mean, again, those alternative treatment recommendations, go on a mood stabilizer, get a psychiatrist, actually end up helping that individual. Yes?
Is it not true that cannabis can induce psychosis?
Yeah. And sorry, that was the implication, right? You know, someone who's actively psychotic should stop using cannabis immediately because they're not going to get better.